This is Jerry Hesch of Hesch Institute in Aurora, Colorado. I practice orthopedic manual physical therapy, and that includes a lot of joint work. Work with the nervous system and work with muscle and ligament and joint movement. You can very clearly see the swelling on the outside of this right ankle. And you can compare that to the left, and you can see there's a distinct difference. She in July was running in grass. It was raining, and then you were running in grass, and you hurt your low back. You had a chronic low back injury already, but doing that, do you think that is what caused this ankle sprain?
No, I don't.
Okay, so when did the ankle start to swell?
I would say probably 2 months ago.
Okay, but no idea why.
No idea why. Probably maybe doing something at the gym.
Could be.
I could have been like
Yeah.
jumping jacks or something of that.
And you also have, of course, low back pain. That's the primary reason you're seeing me.
Right.
And you have pain in the knuckle, in the ring finger on the right.
Yeah.
So as a result of that, you've had a blood workup looking for inflammatory markers, and that was from your family physician?
Yes.
Yeah, and so there was no referral to rheumatology?
No.
Okay.
And I also had an x-ray on my hand and foot.
Very good. And that was negative?
Yep.
Okay. I find that her anterior talofibular ligament, which is the most common sprained ligament in the ankle, to be strong. I find the lateral fibulocalcaneal to be strong. So if I grab the ankle and I try and draw it forward, if there was laxity, we would see some excessive movement here and I would feel it, and that's not the case. And when I test inversion and then I overpressure it, this lateral ligament feels strong. It compares to this side. So we have a mystery there. I've looked for motion dysfunction throughout the midfoot, the cuboid, fifth metatarsal, subtalar joint, moving the calcaneus, actually moving it with the subtalar joint and with the ankle. I've looked at ankle range of motion, and that's symmetrical. All her motions are normal. Here's the interesting, I find one thing, okay, that I'll show you shortly. We'll test her muscle strength. Can you pull your toes up towards you all the way and hold it up? Now, 1, 2, 3, go. Beautiful, very strong. And now I want you to pull the foot up and out, so an outward movement.
Oh, that's right?
Yeah, that's it. That's fine. That's it. Good. 1, 2, 3, give me everything. Beautiful. Excellent strength. So I cannot break that. Sometimes there's a muscle inhibition. The one thing I actually find is at the top of the fibula, the fibular head. Okay? I reach underneath the left fibular head and I stabilize the tibia, okay? And then I spring it forward. And there is the slightest amount of give, which is a normal joint function. When I do that on this right side, there is no fibular motion. There's no give. There should be a little tiny spring mobility. So my treatment is going to be to mobilize that fibula anteriorly and see if that helps this. Of course, with that, it's still good to teach strengthening and balance exercises for an ankle injury. A compressive splint that you can buy at Walgreens or any medical supply house is going to have a compressive sleeve. I think that would be valuable.
Okay.
Certainly apply ice, for 10 minutes a day is helpful.
Okay.
So let's have you lie on your stomach with your feet off the bed. And so I like to treat that fibular head with the client laying on their stomach and the feet off the bed. Okay, and then all I do is, I'm going to retest. Okay, so here, I think the camera can, I think you can see through the film, I think you can see that little bit of spring mobility. Come over here. No, it's absent. There is no spring mobility. And so my treatment is to push it not straight forward because it's a curved joint, but to get a little distraction of the joint, which is what you always want to do when you're trying to gain joint motion. Distraction is very helpful. And so I'm going to push laterally at 20 degrees and anteriorly. And it looks just like this. You can see the angle of my arm, okay? And I like to do this for 30 seconds. And I'm going to teach her husband, Matt, how to test for this. And if it's restricted, I'll teach him how to treat it. So my hands-on intervention is a one-time thing, and that's my philosophy. I don't believe in having people come back repeatedly for me to help them gain motion in their joints. I like to make my clients independent. So I'm sure I've done that for at least 30 seconds. And I perceive motion, whether I'm hallucinating or not, who knows. I expect that I might feel motion. And now I capture that, and now I spring it. And now there is mobility. Okay? So, Matt, once a day, just find this bump. So if you bend her knee, okay, 2 fingers below on the outside, you'll feel a distinct bone. Got it? That's the fibular head. And all you do is push down on it, you know, and spring it. Do you feel that spring?
Yep.
Okay. So if that's absent, then I want you to push it at a 20-degree angle. Just hook it with the heel of your hand and just push against it firmly. You can see I'm pushing till the movement in the leg is absent. The whole leg is rolling a little bit, and then that roll of the whole leg stops, and then I have more isolation of that joint. That's called the superior tib-fib or tibiofibular joint. Okay? So just put the heel of your hand and then show me how you would treat it. Yeah, that's it. That's it. All right? And you can do that for 2 minutes. So, good. I think we're off on a good start. Does that biomechanically contribute to the lower ankle problems? It makes sense. It's the other end of the same bone. Anyway, thank you very much for letting me film and post this. It's a unique presentation.
Of course.